Well, good evening, everybody. Thank you very much for joining us this evening for this webinar on cervical screening in general practice and women's health. Could I ask you all just to mute your microphones while we begin? All right. So I'm Sandy Vincent from the PHN Education team, and I'm joined tonight by Amy Callanan from our PHN Primary Care Improvement team and our two wonderful presenters, Dr. Colette Horrigan and Dr. Lynn Hayes. Before we begin, I would like to acknowledge the traditional custodians of the land that we live and work on and pay respects to their enduring culture and contributions to this vast region. A few things also to let you know that this session is being recorded, and the recording and the slides will be available on the PHN's website in the Education Library in a few days. There is an evaluation survey for this. I'll put the access for that through Slido into the chat, which you can access, and also send it to you via email at the end of the session. We will have time for questions. We will be able to ask those directly at the end of the session, but if you'd like to send through questions during the chat using the chat function, then please go ahead and do that. It's now my great pleasure to introduce our speakers. Dr. Colette Horrigan is a GP at Mariners Medical and GP advisor and educator for the PHN's Domestic and Family Violence Program. And Dr. Lynn Hayes is a GP at Absolute Medical Services and is a clinical editor for the Central Coast Health Pathways Program. Thank you both for being with us tonight. I'm going to ask Colette, who is our first presenter, to share screen and to start your presentation.
Hello, and thank you everyone for joining us tonight for this Women's Health Update. And thank you, Sandy, for the introduction. And I'd just like to acknowledge this beautiful darkened young land on which we live and work, and acknowledge elders past, present and emerging. Now tonight I'll be mentioning a few new products on the market. And I just want to let you know I don't receive any endorsement for this, so I'm not pushing any products at all. So tonight we're just going to look at what our learning objectives are. So to understand who is eligible for a self-collected cervical screening test, and then to be able to explain the process of self-collection to the patient, to understand which patients will need to have a clinician-collected sample, and to understand how to manage low, intermediate, and high-risk cervical screening test results, and to understand some new contraceptive pills that are available, and also how to choose the right pill for your patient. We're going to be looking at the use of testosterone therapy in postmenopausal women. And also we're going to try and increase your knowledge of HRT, and particularly a new HRT that's currently available. So let's first of all look at the new changes to the cervical screening program. So the new changes mean that all eligible screeners, now these are women with a cervix aged 25 to 74, will be able to choose to have a cervical screening test either by taking their own sample from the vagina using a simple swab that we call self-collection, or having a healthcare provider collect a sample from the cervix using a speculum. Now, I talk about women with the cervix, but I want you to keep in mind too, don't forget your transgender patients, because often they won't be coming and asking for a cervical screening test, but they do need one because having a cervix, they're still at risk of cervical cancer. They often will not want to acknowledge female body parts. And also, if they're on testosterone therapy, they may be experiencing vaginal atrophy, and a speculum examination might be quite uncomfortable. So it's a wonderful thing that you can offer them self-collection. Now, both options, that is self-collection and physician-collected, are funded under Medicare now. They're accessed through a healthcare provider, and they're accurate and safe ways to collect a sample for cervical screening testing. Now, self-collection is available anytime an HPV test is needed. So this includes follow-up HPV testing after an intermediate risk result and also cervical screening during pregnancy. And this can be done at any stage during the pregnancy. Now, how do you know if they're eligible? So many patients will not remember when and where they were last screened. And I had a woman just recently, and she told me she had been to another practice and they'd definitely done a cervical screening test on her. She described how she had a speculum inserted. Now, when I went into the register to check, there was no result for her. So I rang the clinic she said she went to, and yes, they had done a speculum examination, but they hadn't done a cervical screening test. So always check the register. Now, the great thing is you can integrate your clinical information system, whether it be Best Practice Premier, Medical Director Clinical, Communicare, with the National Cancer Screening Register by registering using PRODA and the National Cancer Screening Register Healthcare Provider Portal. Now, you can ask your practice manager to do this, and there is a site, ncsr.gov.au, that explains that process, and you only have to do it once. Now, then, once you're linked, if you're on best practice, you can easily access the National Cervical Screening Register. You go up to your top toolbar, you click on View, you scroll down, and then the second last on the list will come up, NCSR Hub, National Cervical Screening Register Hub. Then it will open up, you scroll down, you click on cervical screening history, open that up, and bingo, all their results, way back to when they had pap smears, will appear. Now, the great thing is that you can also see their colposcopy results if they've had a colposcopy on that site as well, and it will give you the histopathology. So you can see whether they've had HPV detected, if they've had cytology done, and also what the recommendation was after their last screening test. So it's a really handy thing to have to check. Now, if we look at screening participation, only about 56% of women are actually participating in screening, and 72% of cervical cancer diagnoses come from the 44% of women who have never been screened or are under-screened. Now, screening is the only way to pick up those at risk of cervical cancer and those with early cervical cancer, as early cervical cancer may only cause minimal or no symptoms at all. Now, screening participation can be increased by putting posters in your waiting room to remind people, sending out the reminders or giving them phone reminders, and checking a woman's eligibility when she presents for a consult. And if a woman needs to be recalled for a test, particularly a co-test, the process is you need to do 3 phone reminders, and then you need to send a letter by registered mail to prove that you've really done everything to contact her. So let's look at self-collection. Self-collected samples are just as accurate at detecting HPV, human papillomavirus, as clinician-collected samples. It's a good option for those who find speculum examinations embarrassing or painful, and it should be offered to women who have been sexually assaulted, as these women often get traumatized by vaginal examinations. Now, it's also maybe more acceptable to women who are physically or intellectually disabled. And I recently saw a woman with quite a severe intellectual disability, and she was absolutely terrified of having her cervical screening test done. She was postmenopausal, and she found the previous one extremely painful. So I actually helped her, and we did the flock swab. So if you're with Douglas Hanley Moyer, it's a red top tube, and I assisted her in doing it, and she was so relieved that she didn't have to have a speculum put in. But just keeping in mind, if you do have a postmenopausal woman and she's got severe vaginal atrophy and she does require a speculum examination, estrogenize her first. Give her 2 weeks of estrogen, stop 2 days before you do the examination. But for this woman, my intellectually disabled patient, I didn't have to put her through that. I could just do self-collection, so that was wonderful. Now, self-collection can only detect HPV DNA with partial genotyping, and it cannot be used for cytology. Now, you have to advise the patient that if they actually elect to have a self-collected cervical screening test, there is, albeit a small risk, 6% chance that they may have to return for a clinician-collected sample if HPV not 16/18 is detected. Now, unsatisfactory self-collected cervical screening tests are rare, but look, if it happens, just repeat within 6 weeks' time. So let's look at partial HPV genotyping. So we can detect HPV 16 and HPV 18. Now, these are the most oncogenic, and particularly HPV 16. So HPV 16 and 18 are classified as high risk, and they'll be found in about 2% of those that are having routine screening done. Now, HPV not 16/18 are less oncogenic and are classified as intermediate risk and will be detected in about 6% of those having routine screening. Now, let's look at the self-collection screening pathway. So there's going to be 3 possible results. No HPV detected, that's classified as low risk. So they will be recalled in 5 years, unless, however, symptoms develop in the meantime. Now, if the result comes back as HPV not 16/18, our intermediate risk, you need to recall the patient for a clinician-collected reflex liquid-based cytology. Now, if it's negative or shows a possible low-grade squamous epithelial lesion, and I'll call that SIL, or a low-grade SIL, repeat the HPV test in 12 months' time. Now, if it comes back as HPV 16 and or 18, then they're classified as high risk. So they require immediate referral for colposcopy, and then liquid-based cytology can be performed then. So if you're referring to a private gynecologist, and they usually get in fairly quickly, then the liquid-based cytology can be done by the gynecologist when they do the colposcopy. However, if you're referring to the Central Coast Local Health District gynae clinics at Gosford or Wyong Hospital, you'll find that they will want you to do the liquid-based cytology yourself, because depending on that result, it helps them to triage when that patient needs to be brought in for their colposcopy. Because as you know, there's quite a big backlog, there's quite long waiting times. So I automatically, if I'm sending the patient to a hospital clinic, I automatically call them back and do that liquid-based cytology myself. Now, I know this looks a little bit messy. So what this actually is it's put out, it's a flowchart by the National Cervical Screening Program. And it's actually worthwhile downloading this. You can just go on and just Google this and go on their website and print it off. It's a really good guide. So what we're going to do is I'm just going to walk you through it now, and you'll see that it actually makes a lot of sense. So what we have is we have on the left-hand side of the screen, if HPV is not detected, then they come back and in 5 years' time. So they're considered low risk. Now, the ones that I really want to talk to you about are the intermediate risk here, where HPV not 16/18 is detected. Now, if they get that result, they have to come back to you for the reflex liquid-based cytology. Now, if that's unsatisfactory, then you basically just ask them to come back 6 to 12 weeks. I tend to do it around about 6 weeks and repeat that. If they come back with either a negative result on cytology, that is, cells are normal, or possible low-grade SIL or a low-grade SIL, then you have to repeat the HPV testing in 12 months, and they can elect to do that with self-collection. Now, if they come back again for a second time with HPV, not 16-18, once again, you have to do reflex liquid-based cytology. Now, if this is where the pathway for intermediate risk differs a little bit. So after 2 positive results, where the reflex liquid-based cytology has only shown low-grade changes, if that woman is over 50, or if she's Aboriginal or Torres Strait Island, or if she's overdue for screening by 2 or more years, then that woman then has to go off for colposcopy. So 2 positive results, low-grade changes on liquid-based cytology in that high-risk group goes off for colposcopy. However, if she's not in the group, that is, if she's under the age of 50 and she's not Indigenous and she's not overdue for screening, then she has a third chance to have another self-collected sample, or if she prefers, physician collected. Now, after the third result coming back, if there's no HPV detected, that woman then goes into the low-risk pathway, where she just has a routine 5-yearly screening test done. Now, if, however, any type of HPV is detected, that means that then that's the third time she's had HPV detected. She has reflex liquid-based cytology done again, and she has to go off for colposcopy. So keep in mind, so they only get 2 chances if they're 50 or over, Aboriginal Torres Strait Islander, or they haven't been screened for 2 or more years. They're overdue for screening rather by 2 or more years. So those women get 2 chances, everyone else gets a third go before they have to go for colposcopy. Now, if, however, they're high risk, that is HPV 16 and or 18 are detected, they require liquid-based cytology. That can be done if they're having their colposcopy soon, at the time of colposcopy, but if they're going to the public clinic, you do that and send the result on to the clinic. Any liquid-based cytology result or unsatisfactory, they need a colposcopy. So if you do the liquid-based cytology and you don't get enough cells, then don't worry. It means you've tried. At colposcopy, they'll do it there. Now, if it's an unsatisfactory test, then once again, repeat, and I tend to do this around about 6 weeks' time. So it's this is where it's quite helpful. Mainly, I find that the pathway for the low and the high risk is fairly straightforward, but it's that intermediate risk. You just have to keep in mind the group that you need to refer on for colposcopy after 2 positive results. Now, those needing a co-test, that is, they need cytology done, are not eligible for self-collected cervical screening tests. Now, anyone who has symptoms that could have cervical cancer, it may be postcoital bleeding, it may be intermenstrual bleeding, it may be unusual discharge, pelvic pain, then they are not suitable for self-collection. Anyone needing a test of cure after treatment for a high-grade intraepithelial lesion, then they're also not eligible. And then anyone treated for adenocarcinoma in situ, AIS, or for a glandular abnormality, aren't suitable either for self-collection. Now, DES exposed. Now, DES is diethylstilbestrol. Now, this was used between 1946 and 1971 on women to prevent miscarriages. However, unfortunately, at the time they were using it, they didn't understand the impact it would have on the daughters of those women, and it's even affected the generation beyond that. Now, what it actually causes is an increased risk of clear cell carcinoma and also adenocarcinoma of both the cervix and the vagina. So this is a group of women who really need to be monitored, and usually they're under specialists for very close monitoring because they're such at high risk, and they are certainly not eligible for self-collection. And also women post-hysterectomy with a history of a high-grade SIL are not eligible for self-collection either. So let's look at how you actually perform a self-collected sample. So it can be done in the surgery behind the curtain, or usually the patients actually go into the bathroom. It can be that at the end of the consultation, you can actually print the form off and take it to your practice nurse, and she can actually go through it with your patient. So basically the patient just lowers her underwear, parts the legs. She takes the tube, which is a flock tube, and as I mentioned, if it's Douglas Hanly Moir, it's a red top tube, and she twists the cap, takes out the swab. She gently inserts the swab into the vagina, and there will be a line marked on the swab to indicate how far to insert it. She rotates the swab in the vagina for 20 to 30 seconds, and it's important to emphasize that. So it's not just a quick in and out. She actually has to rotate it for quite some time to ensure that we're getting a good sample. So I tell them to count slowly to 20, 25, just to ensure that they're taking a good sample. And then she replaces the swab back in the tube. Now, your local pathology provider or the National Cervical Screening Program, they can provide a chart that you can place on the back of the toilet door, which just will remind her of the steps that she needs to take. Now, if the patient also needs an STI test, then don't order it on the same swab. Use a different swab for this. So once again, if it was Douglas Hanly Moir, you would use a orange top tube. And if you don't use Douglas Hanly Moir, if you use Lavity, or if you're using Clinical Labs or one of the others, just check with them to ensure you're using the right swabs. But yes, you definitely need a separate swab. Now, the request form. So it's important to ensure that both the swab and the request form indicate that it's a self-collected specimen. And then on the form, you tick that it's vaginal, that it's not taken from the cervix. Now, it's important to state on the form if the patient is Aboriginal and or Torres Strait Islander, because as you can tell from when we went through that flow chart, it does make a difference for the advice that they give if the patient returns a couple of HPV not 16, 18 results. So it's not possible to put the self-collected swab in liquid-based cytology. It's hard to believe it, but yes, some people actually do this. So it's important to realise that you can't do cytology from the swab, so you can't mix the two. So it's either swab or it's reflex liquid-based cytology from a clinician-collected sample. So liquid-based cytology can only be done with a speculum examination looking at the cervix and taking the sample from the cervix. Now, let's look at a case study. So Jenny is a 28-year-old Aboriginal woman who is asymptomatic and she's never been screened before. She's on a contraceptive pill and she's never been pregnant and has no symptoms of abnormal bleeding, discharge or pelvic pain. Now, she's been reluctant to have a cervical screening test because she's heard that speculum examinations are painful. So after discussion with Jenny, she opts for a self-collected cervical screening test. Now, her result comes back with HPV not 16-18. So let's look at the follow-up for Jenny. So Jenny's one of the 6% of women who needs to return for a clinician-collected sample for liquid-based cytology. She's reassured that a small speculum can be used to minimise the discomfort. The result comes back as a low-grade squamous intraepithelial lesion. So Jenny then is recalled in 12 months for another HPV test. So at that time, Jenny elects to have another self-collected cervical screening test in 12 months, and it returns as a normal result. So there's no HPV present. So then she automatically goes onto the low-risk screening pathway, and she's recalled in 5 years' time. Now, if, however, Jenny had returned a second result with HPV not 16-18, and she either had no cellular changes or low-grade changes, then because she's Indigenous, she would then have to go on for colposcopy. So that's the difference in the intermediate pathway to keep in mind for our Indigenous women. So let's look at the advantages of a clinician-collected cervical screening test. Well, you actually get to view the cervix, and if there are significant visual changes there, that will give you a clue that there could be early or actual cervical cancer present. So I must admit, I always like to view the cervix, although I'm very supportive of patients who want self-collected swabs too. Now, the great thing is STI testing can be done from the liquid-based sample without having to use an additional swab. The vulva can be inspected for lesions. Now, just keep in mind that melanoma can occur on the vulva. I always do, when I'm doing a speculum examination, before I put the speculum in, I always check the vulva. You know, you can pick up all sorts of problems with the vulva in terms of vulval melanosis. You can pick up ulceration. You can pick up vulval warts. And importantly, for women who have lichen sclerosis atrophicis, which is that white scarring change, they're at increased risk of vulval cancer. So you can actually see those changes as well. So visual inspection can pick up a lot of information. You can also look for the presence of vaginal discharge, possible infection. And in postmenopausal women, you can also assess the degree of vaginal atrophy. And also, you can check for prolapses. And I must admit, if I'm doing vaginal examinations, I always just check the pelvic floor as well. Now, we're going to switch over and look at contraceptive updates. There is a new pill on the market, and it's called Nexstellis. Now, it
Colette.
contains...
Hi, Colette.
Hi.
I'm sorry to so sorry to interrupt you. Guys, I just wanted to let you know that your cameras are on unless you have actually turned them off. So I just wanted to check with you because I know sometimes with MS Teams that it's different to the GoToWebinar. So if you do want to switch your cameras off, then please go ahead. That would be awesome. Thank you. Sorry to interrupt you, Colette.
No problem at all. No problem. Okay, so Nexstellis contains drospirenone and a new form of body-identical estrogen, and it's called estriol or E4. Now, E4 is produced by the human fetal liver, but of course it can be reproduced synthetically, which is what's in the pill. Now, E4 is a selective estrogen receptor modulator, a SERM. So it actually has a lower side effect profile. And the good thing is the scheduled bleeding is very predictable. So it's actually good for women who really like to have a regular withdrawal bleed. And the other good thing is there's a very rapid return to ovulation when it's ceased. Now, a pill that's been around a little bit longer than Nextstellis is Slinda. Now, Slinda is a progestogen-only pill. It contains drospirenone, 4 milligrams, and it's the only progestogen-only pill that has a 24-hour window. So as you may remember, our progestogen-only pills up until now have been levonorgestrel or norethisterone, and they've only had a 3-hour window, which is a very small window. So it's wonderful to have a progestogen-only pill now that actually has a 24-hour window, which is comparable to combined or oral contraceptive pills. Now, it provides very good endometrial protection for women with heavy menstrual bleeding. And I've had a number of women recently that I've seen that did not want to have a Mirena IUD for various reasons. And I tried them on Slinda, and it's been extremely effective in controlling their menorrhagia. Now, the good thing about drospirenone is that it's less androgenic than levonorgestrel and norethisterone, and it actually resembles natural progesterone. So it's actually very well tolerated. Drospirenone is the same as the progestogen in Yaz and Yasmin. So drospirenone itself has been around for a while. And the great thing is it's suitable for breastfeeding women and those where estrogen is contraindicated. So now we're going to look at choosing a suitable pill, how you can match your patient with a pill that's going to suit them. So if you have a patient presenting with premenstrual syndrome, which is a really common thing, I'm seeing a lot of women with this, and also there's the more severe form of PMS, which is premenstrual dysphoric disorder or PMDD. Now, basically any contraceptive that stops ovulation will help, because it's the rise in the progesterone level in the luteal phase that triggers the PMS and PMDD. So Yaz, which contains drospirenone, has an indication for PMDD, but the trials that they did were fairly short. So they weren't terribly convincing, although it's been on the market for a little while now, and patients do report that their PMS and PMDD have improved by being on a pill such as Yaz. So pills with the 4-day pill-free interval are preferable. Or if the patient is happy on the pill that they're on that has a 7-day pill-free interval, the other way to do it is just to run packs together. And they can run 3 packs together usually quite happily. But if they get spotting for 3 or more days, I normally tell them to stop, allow themselves to have a period, and then try running 3 packets together again. Now, the other interesting thing too in managing premenstrual syndrome is that there is evidence that adding calcium-rich foods to the diet or taking a calcium supplement can also help PMS. So you can also recommend this as well as putting them on a suitable pill. Now, if your patient presents with acne and polycystic ovarian syndrome, once again, any estrogen pill will help, because estrogen increases sex hormone binding globulin. And by increasing sex hormone binding globulin, it binds to androgens and hence reduces the free androgens. So it's best to avoid levonorgestrel pills because they're more androgenic. So you opt for a less androgenic pill, such as norethisterone, or even better, an anti-androgen, such as drospirenone which is found in Yaz and Yasmin, or Dianogest in Valette. Now, the interesting thing is Valette's been around for a very long time, but it's never really been marketed and not many people know about it, but it is a good pill. If your patient, however, has more severe cystic acne, then consider using a cyproterone acetate pill. And they will come under the names of Estelle, Brenda, Diane, or Juliet 35ED. They're all the same. So with a cyproterone acetate pill, you have to keep in mind, though, that they have a higher incidence of venous thromboembolism. So when you use them, keep using it until the acne is fairly well in remission, and then switch it over to a pill such as Yaz. So my practice tends to be, I find they need to be on a cyproterone acetate pill for roughly about 6 months. And usually within 6 cycles, their acne is usually much improved. And then I drop them down to Yaz, or depending on what their other issues are, perhaps one of the newer pills as well. Now, sometimes patients will tell you that they've gained weight on the pill. Now, there's really no significant weight gain on modern pills. But if the patient feels that they're gaining weight, then the idea is to try a different progestogen, such as drospirenone in Yaz. If your patient's presenting with heavy menstrual bleeding, then the best option really, and what I tell my patients is the absolute best option is actually a Mirena IUD. But some patients don't want to have an IUD and they want an oral contraceptive pill. So don't use a low dose pill because of breakthrough bleeding. Use a pill with 30 micrograms of estrogen, and what you can do is run the pill packs together. Now, the pill that does have an indication for heavy menstrual bleeding is Clara. Now, it contains estradiol valerate and Dianogest, and it works because it has a step down and a step up regime. And if, however, you find that you've used that, and I always check after 3 cycles, so in 3 months, always check at the 3-month mark. If there's no improvement, then always consider underlying pathology and then consider doing a pelvic ultrasound. So if your patient presents with depression, now if the mood change correlates to taking a combined oral contraceptive pill, then consider lowering the dose of estrogen to a 20 microgram dose, or switching from a synthetic estrogen to a more body identical hormone that is found in Clara, which is estradiol valerate, Zoli, which is estradiol, or Nexstellis, which is estriol. And ask the patient to keep a mood diary and review within 3 months. I've had a number of women that I've seen that I've actually swapped from their standard pill to Zoli when they've experienced marked mood change. And it's actually been a remarkable change. You know, they've had no mood change. They've been really, really stable on it. So I do recommend trialing one of the new pills if your patient's experiencing significant mood change. Now, if the patient's presenting with loss of libido, now estrogen in the pill increases sex hormone binding globulin. That binds androgens, and then it reduces the androgen or the testosterone level. So consider a contraceptive ring or even a Kylena. So we're looking at lowering the dose of estrogen as much as possible, like in the Nuva ring, or removing the estrogen and going for a very low dose of progestogen, as in the Kylena. And if your patient is really hormonally sensitive, like with their mood or with their libido, then an option would be a copper IUD. But just keep in mind that copper IUDs can increase the heaviness and the pain of periods. So if your patient is having light periods with no pain, look, it's not a problem. But if your patient has heavy periods and a lot of period pain, then perhaps a copper IUD is not for them. Now, one of the things that you'll find you may get asked a fair bit, I know I do, is about testosterone replacement. So the TGA indication for testosterone replacement is for use in postmenopausal women with hypoactive sexual desire disorder. Now, that is loss of sexual desire for at least 6 months. And often they'll say it goes along with quite a lot of fatigue as well. So for women presenting with prolonged low libido and low energy levels, the first thing you need to do is to measure their testosterone and sex hormone binding globulin. And that is, you can do general tests as well. Keep in mind, just make sure they're not anemic and, or, that they haven't got excuse me, underlying thyroid problems. But do measure testosterone and sex hormone binding globulin, because if their testosterone level is in the upper range, then testosterone replacement isn't going to help them because they've already got enough testosterone. And if you measure sex hormone binding globulin and it's actually really high, then unfortunately, if you give them testosterone, it's just going to bind to the sex hormone binding globulin. So really, they're not going to get any clinical efficacy. So do measure, consider those results. Now, the other thing too in postmenopausal women is reassure them that libido and sexual responsiveness do decline with age. They're not going to have the same libido in their 50s and 60s as they did in their 20s. So we have to also be realistic about that. And look, Rosie King has written lots of wonderful books about that, such as Where Did My Libido Go? So if they're postmenopausal and, however, they're experiencing symptoms of menopause, so if they've got significant hot flushes and, they're being woken repeatedly at night, then before going on testosterone replacement, actually consider menopause hormone replacement therapy. So consider tibolone. Now, tibolone is a selective estrogen receptor modulator, or a SERM. It's based on the wild Mexican yam, and they've reproduced the molecule, and it actually mimics estrogen, progestogen, and also testosterone. So it can be very effective for covering all bases with hot flushes, sleep disturbance, and low libido. Alternatively, you can use estrogen and progestogen. You only need a progestogen if the uterus is present. And then if they're not getting any improvement, then you can add in testosterone therapy after you check the levels. Now, testosterone replacement comes under the name of Androfem 1, and how you'd actually prescribe it. So if you're prescribing it for a woman who has low testosterone levels, her sex hormone binding globulin isn't elevated, you'd start with a half a cc, and she applies that daily. And then you remeasure the testosterone levels 3 weeks later. If still low and she's not noticing any clinical effect, then you can increase to 1 cc and then recheck levels. So you basically keep titrating it. Now, if you check the levels, what you're aiming for is you're aiming to get those levels in the upper range of 1.5 to 2.5 nanomoles per litre. Now, it's important that when you advise her on applying it, you tell her that she has to apply it to 6 rotating sites and they are inner thigh, outer thigh, and buttocks on one side and then the other side. So we have 6 sides. The reason for that is if she keeps applying it to the same side, she can actually get hair growth in that area. But by rotating it among 6 sites, that doesn't seem to be a problem. Now, the reason it's important to monitor the levels is you don't want her to be getting extremely high levels. You might prescribe it, but she might think more is better. So she might actually be using more than you're recommending. And you don't want her to get into trouble with deepening voice and excessive hair growth. So monitor and make sure that she's not putting too much on that's getting her into high levels that could be causing those side effects. Now, it works for some women, not all. So I always get them back in 3 months' time for a review and just see how they're going with it. You can trial it for up to 6 months, but really if she's not noticing any significant change, it's no point continuing on with that. So I'd tell her just to, unfortunately it's not going to be effective, so we cease it. Now, I'd like to just tell you too about a very new HRT or menopause hormone replacement available, and it's by Juva. Now, by Juva, you may already be aware of something on the market called Estrogel Pro, and it's basically got the same ingredients as Estrogel Pro. Now, Estrogel Pro is something that comes with a gel, and it's estradiol gel. And the women are used to apply it from their shoulder down to their wrist. So 1 pump, they'd apply on one arm, and if they were on 2 pumps, they'd apply 1 to each arm. They'd do it before bed, and then they take a little gel capsule, which is micronized progestogen. So unfortunately, that was a lot of women were finding that quite onerous. And I had a couple of women that I was seeing, and they were remembering to take the micronized progestogen, but they forgot to put the estrogen on, and they were wondering why they were getting their hot flushes and sleep disturbance back again. So now, rather than going through that regime, we have Bijuva. So it's a single gel capsule that contains body identical estrogen, which is 1 milligram of estradiol and 100 milligrams of micronized progesterone. It's best taken at night, as the micronized progestogen can cause a bit of drowsiness. It's a very similar cost to Estrogel Pro, and I've swapped a couple of my women over just recently, and they find it just so much easier than having to do the regime of, applying the gel to the arm and then taking the capsule at night. So Bijuva studies actually show no clinically significant changes in weight, coagulation factors, or lipids. And over a 1-year trial, there were no strokes, AMIs, acute myocardial infarcts, or venous thromboembolisms. There were no significant mammographic changes, and there were high rates of amenorrhea, 83% by 10 to 12 months. And women reported their improvements in both the quality of life and sleep. Now, in terms of treating vasomotor symptoms, you basically treat as long as is required. What I tend to do is I tend to review once a year, once they're all stable. And I tend to sort of consider, if we're going to try a withdrawal, we do it over the winter months. And if, however, you slowly withdraw and you find that they get the hot flushes back, put them back on it for another year and then try again to withdraw. There will be a small percentage of women who will need their HRT or menopause hormone therapy basically indefinitely. But do try and get them off, because the majority of women will only need it for about 2 to 5 years, and they will withdraw quite happily. Now, thank you. So I'll just stop sharing my screen.
Thank you, Colette. That was amazing. All right. So hold your questions, folks. I'm going to ask Lynn Hayes, who is going to do the next presentation for us. If you wouldn't mind sharing your screen, Lynn, and bringing up your presentation. Um, Lynn's going to do her presentation, and then Amy has very brief little presentation to do, and then we're going to do some questions.
So thank you so much, Colette, for that wonderful presentation and a reminder of the changes in cervical screening. Can you see my screen, Sandy?
Not yet, Lynn.
Not yet. I'll just do that again. Sorry, just go back. I need to allow it to share, sorry.
There we go.
Okay.
That's coming up. So I can see
Okay.
your desktop. Perfect.
Yeah, great.
Thank you so much.
Yeah, so thank you for a really interesting and informative update, Colette. But if you're like me, you find it's very hard to keep remembering all the new changes of management, medications, and changes in therapy, and also what services are available. And that's why Health Pathways is of so value, to have that on your desktop so you can look up and reference it. So just to remind you of how to log in, Central Coast Health Pathways, the username is Central Coast and the password is OneConnect. And save it to your desktop as an icon so that you can quickly open it during a consultation. So if you want to know and look up again the cervical screening changes, type into the search window cervical screening or CST and press the search button. The cervical screening pathway will come up. I'll just point out a few features here. So in the assessment section, where it talks about taking a history, there is a suggestion to take the previous cervical screening history, and there's a link there to the National Cancer Screening Register. If you click on that button, it opens to how to access the National Register. So this will take you through how to do it, and it will show you what Colette was talking about and how you can do it in your practice. So then further in the assessment, which kind of screening the patient can have. It goes through the different factors to consider. And then how to discuss the screening with your patient, outlining the new program, looking for HPV, the option of a self-collected sample, and what the follow-up would be. Then the sample collection options, there's clinician collected and self-collected specimens. I've opened up for you the self-collected specimen box, and in there it gives information about it. There is a link there to an external document, how to collect the sample. If you click on that, it'll come up with a how to collect your own HPV test, and you can print that off and give that to the patient. So then when the result comes back, the management section outlines what to do to manage the patient. So opening up the self-collected sample test result drop-down box, you can see the different steps to managing it. Now, at the start of the pathway is the link to the Cancer Council flowchart, which I'll show you in a moment. But in words, it has outlined low risk, higher risk, and intermediate risk, and follow-up. So if you click on that cervical screening pathway link, it'll open up that pathway that Colette was showing you, and you can open that up on Health Pathways and refer to it at any time that you want. Then for referral, if they need gynecology follow-up or colposcopy, in the referral section, you will find that there will be a link there in blue. When you click on that, it'll open up to an assessment page. And here are all the private and public gynecology assessments on the Central Coast. I'm going to open up for you to show private gynecology. And for example, there's Dr. Matawa. I've opened him up, and there's the kind of service that he offers, how to refer to him, contact details and website, and all the gynecologists are there. So other women's health pathways that are relevant to tonight, there's the contraceptive options pathway. Within that, there's pathways on combined hormonal contraceptives, and in the management section there, it goes into the different kinds of conditions. You might consider different types of combined hormonal contraception, and then which ones you can choose from. And there's also a link to the newer options that were mentioned tonight, the Clara, Zoli, and Nextstellis. There's the progesterone-only pill pathway. In the background section, you'll find more information about progesterone-only pills, and it does talk in detail, briefly, about the Slinda new progesterone-only pill. In the management section, it includes information about Slinda and how to prescribe it, patient information, and what to do about missed pills. And there's a great section on menopause hormone therapy as well, how to assess someone in the menopause, how to manage their conditions, different options available. I'm just going to focus on something relevant to the testosterone that we mentioned tonight. In the history section of the assessment, there's a suggestion to ask if they're sexually active, if there are any sexual concerns they wish to discuss. And to help break the ice there, and as a way in to assess that, there is a link to a decreased sexual desire screener. And you can take the patient through that and assess their level of interest or get them to fill it out so that you can discover if this is a significant problem for them. In the management section on that page, there's different stages of menopause. If you open those boxes, you'll find different conditions, different regimes appropriate to that stage of menopause. And I've opened up for you the hypoactive sexual desire disorder pathway drop-down box, and you'll see here just briefly outlined steps in managing this condition, including testosterone replacement, and briefly outlines the assessment and prescription and management of that. Another useful thing is the patient information website. So while the Health Pathways is password protected for clinicians, such as doctors and nurses, the patient info site's not password protected, and you can direct your patients there to find information. All of the patient information is listed there that are on Health Pathways, and they can look up things such as cervical screening and read all about it for themselves. If you'd like to know more about Health Pathways, you can contact the manager, Erica Drew, at the PHN, or you can use the send feedback button on every page of Health Pathways. Even if you've got a question, a suggestion, want to know a new service, any feedback is welcome and we'll get back to you. So I hope you'll agree and find Health Pathways really useful as a desktop tool to manage your patients, and just look up those things, have them at your fingertips during the consultation, which is what it's designed to do. Thank you. I'll hand it over to Sandy now to direct for questions. Oh, no, I think there's one more speaker. Sandy, take it away.
That's it. Wonderful. Thank you, Lynn. Always amazing to hear the amazing depth of information in Health Pathways. Thank you for that. All right, Lynn, could I ask you to unshare your screen? That's it. Perfect. Thank you. Amy.
Thank you, Sandy. And just to mimic Lynn's comments, if you are wanting some assistance in navigating how to use Health Pathways in practice, your primary care support officer is more than happy to come out and actually work through the key pathways that you're currently using in practice. So really just to take a couple of minutes of your time and really looking at what both our fabulous presenters spoke about tonight. If you're wanting to focus on looking at improving cervical screening participation rates in your practice, your primary care improvement officer or myself are more than happy to help you in this area. So we have two new key portals and reports that are available to you. So first is our Cancer Screening Community of Practice, which hosts all of our resources around quality improvement, how to import results correctly into your medical software, how to create recall reminder systems, as well as how to access the National Cancer Screening Register, which both Lynette and Colette mentioned. We can actually work you through how to integrate the register into either best practice medical director or Communicare, or access it via Proda. We've created our own user guide, which is quite easy. And like they've both said, it's a fabulous tool to use. So that's all sitting on our community of practice with the web address underneath. Similarly, we've actually just developed a new cervical screening dashboard report, which looks at your de-identified data that you submit to the PHN and creates a beautiful report showing you your patients who are overdue, who haven't been screened and are up to date with their screening, and breaks it down into the patient cohort. So if you are looking at focusing on cervical screening, it gives you a great indication of your patients and where they are sitting with their screening. So how can myself or your primary care improvement officer support you? We can help you look at actually establishing your accurate cervical screening results and participation rates. We can help you analyse your data in practice through these dashboard reports, and similarly look at those patients who are overdue or never screened. The fabulous use of the National Cancer Screening Register, and then looking at systems like your workflows, your reminders, your recalls, and how to actually implement engagement strategies to increase the uptake of screening in your practice. What the work that we do with you as a practice, it does meet a lot of requirements for both accreditation and your incentives, such as your quality improvement incentive and your My Health Record incentive. And working with practices, we've actually improved their screening participation rates in practice by 30% just over a 3-month period by just going through these really simple activities with the practice. So if you're wanting that support, I do apologise, I've got a child next to me right now, but if you are wanting that support, please reach out to myself. My email address is at the bottom, or you can speak to your primary care improvement officer, which will either be Sarah, Sandy or Kathy. And I will hand back over to Sandy. Thank you so much.
Wonderful. Thank you so much. So thank you to all of our presenters tonight. That was really informative session. We would like you to have an opportunity to ask any questions. So I don't see anything in the chat, but if you want to unmute yourself and put your cameras on, please by all means. We'll hold for a minute and let you do that. All right, folks. It doesn't look like we have any questions. All right. Is that somebody wanting to? No? Okay. All right, folks. I'm going to wrap it up. It is past 7:30 and I want to thank you all very much for joining us. Please do complete the evaluation, which is in the chat, but I will also email the link out to you. And it just remains for me to say thank you very much and have a very good evening.
Oh, thank you. Thanks so much for joining us tonight.
Thank you, everybody.
Bye. That was really good, Lynn. Thank you.
You're welcome. I was a little bit short of time there at the end.
Yeah,
and,
sorry.
so I had to rush it a little bit.
I think I went a bit over. I didn't realise because when I timed it, I was under. I must have slowed it down.
Colette and Lynn, we've still got people with us. Hang on, not everyone's left just yet.
Your daughter's gorgeous, Amy. Hello.
Do you want to say hello?
Hello. She's gone shy.
She has.
Oh, how old is she?
4. She did really well to get through.
Oh.
She said that she wants her little sorry, Sandy, I think you've got a question that someone's popped her hand up.
Gabrielle. Yes. Gabrielle? Hang on, Gabrielle.
No?
No.
All good?
I think maybe they put their hand up when they were trying to hang up.
Probably. Probably. Oh my goodness.
What a relief we had no IT issues that went off. That's great.
Exactly. And you guys did a champion job. Well done. Well done. Very smooth transitions. Lovely. That was awesome. So thank you very much.
And you did well then, because it sort of worked hand in hand, like one
Yes.
was followed on from the other. They weren't like two separate things. It was great.
Yeah. I looked at your talk before I did mine